Hi, my name is Elisa Minkin. I'm a general pediatrician. I'm also chair of the Jewish Orthodox Women's Medical Association Preventative Health Committee, and I am awestruck to be here today with Dr. Aaron Glott, Rabbi Dr. Aaron Glott. Rabbi Dr. Aaron Glott is the chair of the Department of Medicine at Mount Sinai, South Nassau. He also serves as the chief of infectious diseases and is at the hospitals and is the hospital's epidemiologist. Rabbi Dr. Glott is board certified in infectious diseases and internal medicine. He completed a fellowship in infectious diseases at the SUNY Health Science Center at Brooklyn, New York, and served as chief resident in internal medicine at Brookdale Hospital Medical Center. Considered an expert in infectious diseases, he is a spokesperson for the Infectious Disease Society of America. He is also a practicing Orthodox rabbi. Thank you, beyond thank you, for doing this with me.
My honor and pleasure. Thank you for having me.
The honor is mine. Thank you. So everyone is talking about the COVID vaccines, and that was originally going to be my topic. And I'm glad that other people are covering it. I do want to do some of it, but meanwhile, so many people are getting the virus. The hospitals are getting overloaded, and we do have information on treatments that I think people need to hear more about. So I did want to start with those, starting with monoclonal antibodies, please.
Sure. So the FDA has given what we call EUA, Emergency Use Authorization, for two different companies' products, one from Lilly and one from Regeneron. The first one that got that special EUA, Emergency Use Authorization, was the Eli Lilly product called bamlanivimab. And this is a monoclonal antibody that has been shown to be effective in very selected populations, in people who are recently, unfortunately, exposed to and infected with COVID, who have, within a period of 10 days of their initial symptoms start, as well as they have other underlying risk factors, putting them at higher risk for the development of, heaven forbid, serious COVID difficulties, significant COVID illness. And this monoclonal antibody, the one that was first came out, this, I'll call it BAM, just because it's a little bit easier to say bamlanivimab every time. So we'll call it BAM. That was the product that those of you that keep track of these things from public figures, that Governor Christie, the former governor from New Jersey, had received. And this has been shown to prevent more severe illness and progression of more severe illness when given under those parameters. There are other recommendations from the EUA as to other people at high risk that should be getting this, but basically if you have age above 65, or if you have age of 55 and have some underlying conditions, or if you have significant morbid obesity, if you have a BMI above 35, if you have significant other medical problems, you might be a candidate. It's also a group of pediatric patients that would be candidates as well, who have, again, significant underlying illness. This should not be given to a person who goes to a local place because they've been potentially exposed to somebody, gets a PCR test and is positive without any symptoms whatsoever, especially if they have no underlying medical conditions or if they have no risk factors for more likelihood to develop severe illness. So it should be reserved. There's limited quantities of it available. It requires a infusion, which means that it must be given in an infusion center. You can't get this in your doctor's office. It has to be given in a place where they can, heaven forbid, treat the risk of anaphylaxis. Anaphylaxis is when you get a severe allergic reaction, and 1 in 425 people in the studies that had received these monoclonal antibodies got this anaphylactic severe reaction. So it should be given in a setting where you can definitely address that, take care of that, heaven forbid should that occur. And in addition, one has to understand that this is an experimental agent. It doesn't have FDA approval. So there's a whole consent process, and it takes an hour to get the infusion. You have to watch them for an hour afterwards. They have to be properly enrolled, properly getting informed consent. So it's not a simple thing, and it needs to be done in an infusion center most of the time. We at our hospital and many other hospitals have set up special COVID infusion centers. You don't want to put this in your regular infusion center next to this patient with COVID, next to a patient who's getting chemotherapy and is very, very brittle. So you need to separate it into, and what we've done is we have a separate area and a tent outside, actually, the winterized tent, and that we call our COVID infusion center. And we can give this product from Eli Lilly, bamlanivimab, and do it in a proper way. And we've given a significant number of doses already to patients. Subsequent to the authorization for the Lilly product, the Regeneron product, which is a combination of two monoclonal antibodies, casirivimab and imdivimab. So these are two monoclonal antibodies that can be used together. They're two vials, and you give both of them to the patient in exactly the same fashion as the bamlanivimab. And it is also shown through the emergency use authorization, the documentation from the studies, that it can prevent more severe disease. So these are wonderful treatment modalities. The Regeneron product, the double monoclonal antibody product, was the one that was given to President Trump, for those that are keeping track of which celebrities get these monoclonal antibodies. And it, again, is effective in preventing some of the complications, some of the more serious illness that we've seen in higher risk patients. And that's what it should be reserved for. The inclusion and exclusion criteria are identical between the two monoclonal products, the Lilly and the Regeneron product. And if you're already symptomatic and you require oxygen, it's too late. There's no evidence that it works in that group. There's some suggestion it may actually be harmful or not helpful. And it must be given in this very small, tight window from the time that you get the diagnosis and have some symptoms. You have to have some symptoms. You need to have a positive PCR test as opposed to a rapid test. We only give it to people with a positive PCR test. And in this group of patients, we have believe we've seen some benefit. We haven't done a large enough number of them to be able to statistically say that it definitely prevents progression to more severe illness, but the studies that are out there, and there are small studies out there, have shown that it is beneficial. So this is one of the newest treatments. This only became available in November, and this is one of the newest treatments that we have for especially the highest risk patients early on before they run into trouble. We know that these patients are unfortunately much more likely to develop significant pulmonary symptoms, difficulty breathing, shortness of breath, oxygenation problems, heaven forbid, require very significant oxygen support, including even, heaven forbid, intubation and requiring a tube being put down for them to breathe in. And heaven forbid, this is the group of patients that has the highest mortality. And therefore, these can be very important life-saving measures. So when especially people at higher risk for progression to severe illness are diagnosed, they should make sure that they are followed by a physician that is familiar with the progression of COVID illness and can decide that they're an appropriate patient to refer for these monoclonal antibodies to a hospital or an infusion center that is set up to do this, like we are at our hospital, for example.
So Mount Sinai South NASA has these infusion centers. Do other places have them?
So there are other hospitals that have them as well. I don't have a list of all the hospitals that do this, but most of the larger hospitals, most of the tertiary care hospitals, either within their system have one place or two places that may do this, or have even more places that may do this. And the physicians in your community will hopefully be attuned and know how to refer somebody in your community, wherever your community is, how to get the monoclonal antibody treatment infusions as appropriate. So one-time infusion. And again, it's not for everybody, but it is something that be considered in the highest risk patients.
What kind of data do we have on how well it works?
So in some of the preliminary studies, it does seem to prevent maybe even up to 6 times as likely to prevent hospitalization and some of the more serious complications. Has not been shown to diminish the death rate, but that may be just a factor of not enough patients, and thank God, not enough patients die, and not enough patients have been enrolled in some of these studies to be able to show that that is statistically a benefit from it. But it certainly would make sense if you're not going to have as many hospitalizations and if you're not going to have a severe progression of illness, that there may be a death benefit as well in terms of preventing the horrible complications of COVID.
Right, and I know that it's new also for this BAM, I can't say it.
Bamlanivimab.
Right, I've heard it called BAM. Anyway, to be available for children, and I know I'm a pediatrician and we've been confused in my practice because they've said that it could be as little as a body mass index of 85th percentile, which doesn't really seem like a high risk factor for children who statistically often do well. So, I mean, what do you think about who should be getting the BAM?
So I think that the experts, the pediatric infectious disease people, the pediatricians that are dealing with this on a regular basis need to make those decisions. In our infusion center, we have not been giving it to children, partially because of our referral practices, but it certainly has emergency use authorization in high-risk children. While in general, thank God, children do very well with COVID, and many of them have mild illness. So similar to the old coronaviruses, the novel coronaviruses don't necessarily cause that much more difficulty in young children. There are some young children, heaven forbid, that have died from COVID-19, and there are those that have the severe heart problems that have been associated with COVID-19 and other long-haul complications. So while it's much less in young children, it is not zero problem. So in the highest risk children, a knowledgeable pediatrician with or without a pediatric infectious disease oversight should consider it for those patients.
Right, so I think that's a good tip to consult with an infectious disease. If you're listening to this and you're a pediatrician, consult with an infectious disease physician.
Especially an institution that has familiarity with it.
Mm-hmm.
I would dare say there's, thank God, very few pediatric patients that are getting COVID infusion therapy. So this is not something that even a very well-trained and knowledgeable pediatrician who care for a lot of patients with COVID may be familiar with.
Mm-hmm. Absolutely. How does this compare to COVID plasma? The COVID plasma initiative?
Right. So the giving of what we call convalescent plasma, that means that people who had gotten COVID themselves developed significant levels of antibody. The Mount Sinai test actually was the baseline marker that the New York Blood Center and many other centers across the country and the hospital systems of the country used the Mount Sinai laboratory testing to develop antibody testing. And the Mount Sinai test actually has FDA approval. There are very few tests that do have FDA approval. So it's a very good sensitive test. You can essentially show that 100% of the patients who have had COVID will have a positive test with the Mount Sinai antibody test. And you can do even fancier testing to show 100%. But let's assume it's either 99% accurate in terms of picking up people who've had COVID in the past. So that's a very good, important thing to know, especially if their COVID testing was negative. And that's one of the uses we have for antibody testing in somebody who you think had clinical COVID, but their COVID testing was negative. In a paper that we published, we showed that you're only going to pick up COVID positivity about 80% of the time. That means about 20% of the patients who had COVID have a negative PCR test. That may be due for a number of reasons. Could be sampling error, you didn't do the test right, or it just doesn't show up. There's a variable amount of genetic material in the nasopharynx at any one given time, and you just may miss it. In any event, the antibody testing was done on people who had recovered from COVID, and they showed that there were people that had very high titers, and a cutoff in the Sinai test of a 1 in 320 titer was used, and all of those people were eligible to donate plasma. They all were recovered, and their plasma was taken by the New York Blood Center and then given to patients, roughly a 1-to-1 ratio. You sometimes you get a little bit more from one person, but basically a person who had COVID could then donate plasma. Their plasma has the antibody that will hopefully be helpful in treating somebody who has active COVID. And we treated hundreds of patients with convalescent plasma. Unfortunately, the published literature do not show a tremendous benefit for this. And at the current time, the official recommendations from the NIH and the Infectious Disease Society and others is that it's still an experimental therapy and shouldn't necessarily be given to somebody. It doesn't mean that it can't be given to somebody. It does have such authorization, and it doesn't mean that it shouldn't be given, but it doesn't mean that it must be given. And I think each clinician needs to decide for themselves on each patient on the decision, should convalescent plasma therapy, should that type of therapy be given. We're about to embark on a study, and other places are also giving what's called hyperimmune gamma globulin. And this is basically a product that has very high, well-known concentrations of the antibody. And I think this NIH-sponsored study will be very helpful in determining, does such therapy really work or not. One of the problems with convalescent plasma is that you're doing the test on a person a week or two before they actually give or donate the convalescent plasma, and you don't know what actually is their level at that time. And we also use a cutoff of 320. So that means some people with 640 and some people with twice that and 3 times that titers, they're all lumped in together. So it's very hard to show a benefit when you're not giving a standardized product. So I think that the hope will be with these types of hyperimmune gamma globulins, similar to the Zigs and the rabies gamma globulin, at a very high concentration of gamma globulin, that you can give a set amount, a standardized amount, a high amount, much higher amount than you would otherwise normally have in a typical person's convalescent serum from their convalescing from their personal COVID illness. And this way we can then test it. We'll have a 50-50 chance, placebo versus a blinded a protocol getting the hyperimmune gamma globulin, and then we can see whether it works or not.
Right. So right now, So right now we have more variability in the COVID plasma.
Right. Part of the problem with some of the therapies that we've done is that we haven't really tested them properly. And, there's a report that it worked in 3 patients, and suddenly 300,000 patients are getting it. It's impossible then to enroll anybody in the study because it works, it's great, it's the best thing since sliced bread. And nobody wants to be in the placebo group or take a chance of being in the placebo group. And we saw that, unfortunately, with several different types of therapy when we were so desperate to try to find something to give our patients who had unfortunately so sick and dying in front of us. The original numbers of patients that were dying in March, April, May in New York from all medical centers were in the 20% area. These are a selected group of patients, not 20% of all people that got COVID. These are of people that got hospitalized with COVID. 20% plus were dying. So we were desperate to try to give something to these patients, and people were grasping at straws. There was a paper with 7 patients that seemed to be a benefit, and there was another paper with 4 patients that seemed to be a benefit, and those things became standard therapies. And that's not the right way to practice medicine. And unfortunately, that's sometimes the way that it has to be practiced because you're desperate.
Right. And I think that that's always a tension between evidence-based medicine and people who are living it right now with no known, proven super efficacious therapies. And that's come up with hydroxychloroquine. It's coming up again with a medication called ivermectin. And, it's good to hear your thoughts, and I'm happy to hear more on them so people will understand that nobody's holding back effective therapies here.
So I think people have to realize that just because somebody had a small series of patients that may or may not have been a good study, and they had some benefit from it, doesn't mean, and there are unfortunately hundreds of examples in the published literature with other drugs where the preliminary results were very promising, and then the real results were unfortunately detrimental at worst and of no benefit in the best case scenario for a therapy that's not beneficial. At least it didn't hurt you. But sometimes these therapies can actually hurt you. There are side effects with all of these medications. And when you start giving them to hundreds of thousands of people, so then you're going to start seeing side effects. And we just don't have enough information to recommend it. And that's why it needs to be studied. And that's why the experts in the field, and people need to trust experts and understand that the experts are unbiased people. I have no skin in the game whether ivermectin works or not. Nothing would please me more that ivermectin works. It's a drug that's used to treat scabies and other illnesses across the world, parasitic infections. So it's a drug that we will willingly give if there's an indication for it. But because somebody with a social media platform, even if they have the word MD after the name, says everybody should be taking this and we shouldn't waste any more time and the case is closed, well, we've seen the harm that can do. I mean, we gave a lot of different medications to patients with COVID, and most of them have now subsequently been shown. I don't mean me personally, I mean my hospital personally. I mean the medical community across the country was giving all sorts of interleukin-6 inhibitors, interleukin-1 inhibitors, and the studies have not shown that they're very beneficial. In fact, with some of these drugs, there are side effects. So we have to be very careful. We do believe in evidence-based medicine. You don't have to have everything perfect. When you're dealing with something like COVID, I don't need to have a 5-year double-blind prospective study with follow-up. You don't need that, but you need to have something. You need to have a little bit better than it worked in a very small series of patients without a control. And I think that's what everybody needs to understand. And even if there was a small control population, a small study, that's, again, all the more important to do a larger study rapidly and quickly. And this way we can get accurate results.
All right, and there's also an opportunity cost, because if you have therapies that we know have proven efficacy to the point of at least getting an EUA, and you're busy doing something else, you may not be able to get therapies that have greater evidence.
So yes, there's always a concern. And I think, again, outside of a study setting, I'm all in favor of people enrolling in studies. If you'd ask me, if somebody would call me up and say, I could possibly enroll in an ivermectin study, it's a 50% chance I'll get ivermectin, a 50% chance I'll get placebo, I'd say go for it if you want to. I can't say you must, and I can't say you shouldn't. It's a personal choice to enroll in a study like that. If somebody would ask me, is it a reasonable thing to do? I would say it's an extremely reasonable thing to do, as long as they give an informed consent, as long as they explain what the risks and benefits are. So both from a medical point of view, from a religious point of view, putting on my rabbi hat, I think it would be
Mm.
perfectly fine to enroll in such a study. Not a problem at all. But it doesn't mean that the guy next to you should be saying, well, if they're in a study for it, then it must be good. I should definitely take it and demand that my physician give it to me. I think that would be a mistake.
Right. Now, for people who have COVID, say, a certain percent will be asymptomatic, a certain percent will be mild. As it gets beyond the mild, not everybody's going to qualify for the monoclonal antibodies. And we didn't talk about how you could qualify for the COVID plasma, which so far
So
we don't have as good evidence.
right. So for the monoclonal antibodies, you have to not really need oxygen supplementation. Once you've
Mm.
reached the point where you need oxygen supplementation, it probably isn't going to be of help. And again, as I said, there's potential that it could be harmful. So we don't recommend it being given. The EUA doesn't allow you to give it under those circumstances. It's not an FDA approved drug. If you want to give an FDA approved drug for a non-FDA approved indication, you're allowed to. But for an EUA, you technically cannot do that. But I don't want to get into technicalities here.
Right, right,
It
right.
shouldn't be done because there's no medical evidence to support it in that group of patients. So there is evidence that remdesivir works. Now,
Mhm.
remdesivir is an antiviral. Remdesivir is a okay drug, not a panacea. It is not going to save the world, but we have given a tremendous amount of remdesivir, and we have seen patients have some benefit from it. And there are published studies. Controversial drug. The WHO does not agree with the position of the CDC and the Infectious Disease Society and the NIH and other groups that do feel remdesivir has a role. My humble opinion is that the WHO is wrong. I think that they've made a mistake and that they've analyzed something in the specific and therefore generalized it to everybody else. So remdesivir shouldn't be given to people that don't merit the remdesivir criteria. But I do think that remdesivir has been shown to be of some benefit in selected patients. It is an IV drug. There is talk of a inhalational form. You can't give it orally, it gets destroyed by the liver, but there is an inhalational form that's being studied. There are other forms of inhalational therapy with interferons that are being looked at. Not everybody should be getting interferon, and not everybody should be getting everything that has been touted to potentially be of some benefit. People are arguing that you should get various types of antacid type drugs, and they have not been shown to be of benefit. Again, the significant inhibition of the interleukin 6 system, that was a tremendous amount of tocilizumab was given out, and other medications like that. They just haven't borne out in studies, and they're no longer recommended to be given. You talked about hydroxychloroquine, the same thing. Tremendous amount was given, and there are 40 or 50 studies looking at it with some mixed results, but the bottom line is they're not recommended to be given. So again, every clinician has to make certain decisions for themselves based upon sometimes not 100% clear literature. But I try to follow what the experts say, where I have my own personal experience, my own personal data that we've published or that we looked at. So then I try to follow that. And I think that remdesivir has been shown to be of some benefit. One drug that really has been shown to be of significant benefit in terms of preventing death and severe outcome is dexamethasone.
Methadone, right.
Good old steroids, Decadron. So other agents like Decadron should work just as well in a certain set dose, not the massive doses that some people are giving, and not for massive durations of time. It's really only recommended for a 10-day period of time. And again, it's not recommended early in illness. People who, oh, I have COVID and I have a little cough and some shortness of breath, put me on steroids, that's probably dangerous, besides not being helpful. There are a lot of complications in people taking 10 days of high dose steroids. And one should not do so except under the supervision of a physician, prescribed by a physician, not because you happen to have some in your closet from whatever the reason, or you borrowed from somebody, or you're able to get it somehow. You should do it under the supervision of the physician, and most of the time these should be patients that have significant level of symptoms and they've had illness for a significant period of time, usually for at least 10 days period of time. And then steroids may be a tremendous benefit in preventing severe progression of illness and death.
Can these be used as an outpatient? Because I know this was discussed in another
So
webinar I was in.
it should not routinely be used as an outpatient, but as some physicians are capable in their practices of giving significant levels of supplemental oxygen on the outside and following sick patients on the outside. Mount Sinai, for example, has a program of hospital at home. So you're getting pretty much hospitalized care. So of course you can give steroids in that quote outpatient setting, because it's really like an inpatient setting. I think the problem is when people who don't merit steroids based upon their illness get it in an outpatient setting. That's terrible. And patients that were admitted for a non-COVID reason but happen to have COVID, so now they're in an inpatient setting, they certainly shouldn't get steroids if they don't have, thank God, we have patients admitted all the time to give birth. And we test everybody, and you're going to find the general rates in the population are in the women who are giving birth as well. So of course you shouldn't give them steroids. That would be dangerous. So we don't want to recommend based upon your inpatient or outpatient setting. We want to base it on how long you've had symptoms, how severe are those symptoms. Are you being managed with supplemental oxygenation inside or outside the hospital? That's the critical factor, not where you physically are.
Right. So I think the take home is work with your healthcare professional. We're not here to give medical advice, but don't try this at home.
Absolutely. I think I'm amazed at how many people are getting their care from either Google or getting their care from an email. And I think anybody, especially if they have significant underlying risk factors or age, needs to hook up with a physician. It can be telehealth. It doesn't have to be an in-office visit. It can be, how am I being monitored in terms of oxygen saturation? They should get an oximeter and measure their oxygen saturation with a pulse oximeter, the little thing you put on your finger, and measure your oxygen saturation. You should do it several times a day, especially if you have higher risk. If those numbers are pretty good and you have no difficulty breathing, you're doing okay. You probably don't need much else. You don't need fancy laboratory tests. You don't need usually a ton of other things that get taken if you're in the hospital, for example. You don't need daily x-rays, and you don't even need any x-ray necessarily. If the clinical picture is appropriate, then you get an x-ray. Your physician should order that. If the oxygen saturation is good, your breathing is not a problem, you're able to carry on your normal daily life activities, well, keep on being monitored. See what happens tomorrow. But you don't need medication in that situation. The only exception might be monoclonal antibody. A physician needs to make a decision. Do you fit the inclusion/exclusion criteria? Otherwise, let's hope and wait it out that you're going to do well, because we really don't have much else to offer you, and you don't want to be in the hospital if you don't have to.
Right. And speaking of that, I have to say, we say it over and over again, but the best prevention is prevention, right? And it goes back to the masking and the distancing and trying to avoid getting COVID in the first place. We can't say that enough. It's not simply, oh, well, I don't mind getting this because now we have treatments.
Absolutely. I couldn't think of a better way to end. I have to unfortunately end our discussion.
Oh,
I couldn't think of a better way to end this discussion than to remind people that even with the vaccine coming up, and maybe people can talk to you. I'm giving a vaccine whole discussion tonight. I'm giving a medical grand rounds on it next week at Mount Sinai, South Nassau. Physicians, other healthcare providers are welcome to join that. The most important thing, even with the vaccine, even with all the monoclonal antibodies and steroids and everything, is you don't want to be in a situation where you need those. And except for the vaccine, which everybody should get as soon as it's available. I got vaccinated. I think it's fantastic, and everybody should get vaccinated as soon as they can.
Right, I'm waiting my turn.
I'm still masking, I'm still social distancing, and I'm still washing my hands appropriately. The latter will be for the rest of my life. Always wash my hands.
Right.
All right. Social distancing, I hope we can eventually do without. But for the next few months, for certain, until we reach a certain level of herd immunity from the vaccine, the masking and social distancing are going to keep many people alive and not having to ask me or anybody else, do I need the BAMs? Do I need the steroids? Do I need hospitalization?
Yes, I can.